Okay, looks like we have most everybody here. So, hi everyone. Thank you all for attending Envia Fertility's patient education webinar today on egg donation and surrogacy. My name is Brian. I'm our current practice representative, and I'll be your host for this informational session. Alongside myself, I'm honored to present to you the panelists of our webinar, Dr. Sigal Klipstein and Vicki Maher. Dr. Klipstein trained at the University of Chicago for medical school, then completed her residency and fellowship in reproductive medicine at Harvard University. She will be speaking today about egg donors. Vicki has been with Envia since 2006, serving as our egg donor and surrogacy coordinator. She screens all incoming egg donor applications and guides patients through their journey to parenthood. Today, she will be speaking about surrogacy. So Envia Fertility Specialists has 3 physicians in total, Dr. Pushek, Dr. Karande, and Dr. Klipstein. All 3 of these physicians are board certified in the specialty of obstetrics and gynecology, as well as the subspecialty of reproductive endocrinology and infertility. We also have 4 locations for the convenience of our patients. Our main office is located in Hoffman Estates, where our surgical suite and embryology lab are located. We also have satellite offices in Arlington Heights, Crystal Lake, and Northbrook. So as we get started, if you have any questions during the duration of the webinar, please type them in the Q&A section provided, and we'll have time at the end for a question and answer segment. Now I'd like to turn it over to our 2 presenters to teach us more about egg donation and surrogacy. Hang on one second, everybody. There we go.
All right. Hi, I think I am in. Hi, I'm Dr. Sigal Klipstein. Thanks. Sorry for the technical difficulties. I'll be talking today about egg donation. And I wanted to just briefly outline the things I'll be talking about. So first of all, reasons to use an egg donor. Why would you want to do that? What are the characteristics of egg donors who donate? How to find an egg donor, using known versus anonymous egg donors. And I put anonymous in quotations. I'll show you why in a little bit. Screening the egg donor, what is the process? And then some additional considerations that we should think about, including the emotional, legal, and financial aspects. All right. So what are some reasons you might need a donor? You might have diminished ovarian reserve. So you've been trying to get pregnant, but for some reason the ovaries have less eggs in them than they might otherwise. Perhaps you've gone through multiple IVF cycles and not succeeded in achieving a pregnancy. It's possible that a woman has had cancer treatment that affects her fertility, chemotherapy, radiation, sometimes treatments for medical conditions, not just cancer, can affect fertility as well. Rheumatoid arthritis, things like that. And of course, if you're a same-sex couple, 2 male couple or a single male, then you would need an egg donor. And premature ovarian failure, which by definition is menopause before age 40, but some women even in their 20s and 30s stop having menstrual cycles and can benefit from an egg donor. And also avoidance of genetic diseases. So for example, if you carry a disease or you and your partner carry a disease that you know might affect your baby, instead of using your own eggs, you might choose to use an egg donor to avoid having a child with that particular disease. So who donates eggs? Usually it's young women between the ages of 21 and 30. They're overall healthy and they're interested in helping a couple or an individual or donating to a single male or a same-sex male couple. Many of the donors who donate anonymously don't know, who they'll be donating to, and they understand that it might be a range of different family building options. Now, the donor may or may not have had children of her own. And when we looked at this and looked at success rates, it's nice to sort of know that the donor's had children, so you know that she's had kind of what we call proven fertility, but it does not make any difference in the outcomes. And so whether you choose a donor that has already had children or not does not impact your chance of success. All right, so what are the two biggest decisions? The first decision is to choose to build a family with egg donation, and it's not an easy decision and not easy to come to. And the second decision, once you've decided to use an egg donor, is selecting which donor to use. So what about the known versus the unknown or anonymous? We no longer call them anonymous, and I'll talk about why that is. We call them non-directed donors. And so a known donor could be a family member, could be a friend. That person may or may not be reimbursed for her donation. A non-directed donor usually is recruited by a fertility center, an egg donor agency, or an egg bank. The identity of the donor and recipient are not shared, and the donor is usually reimbursed for her donation. All right, so how do you find a donor? Like I said, you might have a sister or a best friend who is interested in donating. Most people don't have that or don't want to work with someone that they know so intimately because it can get a little sticky in the relationship, and it's a little bit easier emotionally, I think, to use an unknown donor. So we, for example, at Envia recruit our own egg donors, and it's a very selective process, and we screen them in ways I'll talk about in a few minutes. You can go to an egg donor agency. These are for-profit centers, and they recruit young women to donate eggs. Generally, they're a little bit more expensive. And the third option is via an egg bank. And so this is a little bit different. When you use an egg donor from a fertility center, an egg donor agency, she is doing an IVF cycle just for you. She is then giving you all of her eggs that you can fertilize with your partner's sperm or a sperm donor, whatever you choose. And then all of those resulting embryos are yours. If you use an egg bank, women can donate to an egg bank. And so a number of their eggs, usually perhaps they make 10 or 15 or 20 eggs. Those are divided into different batches of eggs. And you would be purchasing essentially a limited number of eggs, 5 or 6 or 7 usually. And somebody else might have another batch of eggs from the same donor. So let's talk a little bit about anonymity. Years ago, when we did egg donation, we said, look, we're not going to reveal any information to the donor about you and to you about the donor, and the records are sealed, and short of a court order or other situation, we wouldn't unseal them. But I would argue that there's no such thing as anonymity today, and why is that? Initially, there was facial recognition software, and that still is out there and getting better every day, but even more so, many of us have given a sample of our DNA to one of these direct-to-consumer DNA companies, 23andMe, Ancestry.com, and these companies share your genetic or have a copy of your genetic information. And so, for example, you can imagine that if your egg donor provided a sample and your egg donor baby also provided a sample, they could find each other. But even more so, let's say you have a baby with egg donation and that egg donor's sister or mother or aunt donated. Well, there would be a genetic match, not as close of a match, but a genetic match. And so you could potentially envision a future in which you find each other. That has a lot of implications in terms of what you tell your children about their origins. So if you look here, this is a little graph showing the explosion of direct-to-consumer DNA testing by the two main companies and others in the market. And you can see that currently there are about 26 million people that have already donated, or not donated, but given their genetic material to one of these companies. But by 2021, which is next month, this number is expected to reach 100 million. So essentially, with 100 million people, almost everybody can find one another through some distant connection or not so distant connection using these DNA test options. So just something to think about. So how do you choose an egg donor? Most people want someone that wouldn't look out of place in their family, so they look first at physical characteristics. Then they look at ethnic background often, health and education, and really we provide you with a whole lot of information about the egg donors. And so what's important to us is that you pick based on what's important for you. And everybody has a different weight that they assign to the different characteristics that might be important to them. And we'll work with you to help you find the best match you possibly can. Sorry, just trying to advance. There you go. So we often get asked if you should use what we call a proven donor who's had a successful pregnancy through an egg donation in the past, or a first-time donor. And again, similar to using a donor who's had children of her own, we find that whether the donor is been successful in the past or not does not change the chance of success of a donation for you. So while it might provide some reassurance to know that the donors had success in the past, it's not necessary. And if you find your dream donor and she has not donated before, it's absolutely acceptable and recommended to give it a chance, because it will not decrease your chance of pregnancy. So how do we screen donors? We're very selective in our process and very rigorous. And in fact, if we look at any given year, generally only 3 to 5% of applicants are ultimately accepted. And so what do we look for? First of all, we do a medical screening. We look at ovarian reserve. So does she have a lot of eggs in her ovaries? We look at follicle stimulating hormone, anti-Müllerian hormone. These are hormones made either in the brain or in the ovary that give us a really good clue as to how many eggs she'll make and how fertile she is. We also look at something called the antral follicle count. So if you look at an ovary, you will see a number of follicles. And so the more follicles we see, the more likely we are to get a good number of eggs. And so we can determine more or less how many eggs we would be likely to retrieve by looking at that. And of course, we look at the health history in great detail. Beyond that, we look at infectious diseases. So it's interesting because there's no evidence that you can transmit any kind of infectious disease through an egg. You're really getting just one cell. That's all an egg is one cell. But nevertheless, we follow all of the FDA guidelines, and we think it's important to do all this testing. So hepatitis B, hepatitis C, HIV, syphilis, gonorrhea, and chlamydia, and all of the agencies and the egg banks will do the same. So you can rest assured that the donors have gone through quite a rigorous infectious disease screening. We also do genetic carrier screening. So we want to make sure that if the donor carries any kind of genetic disease, that does not provide a risk to you. So we test for over 200 diseases, and the donor also undergoes a consultation with a licensed genetic counselor. Now, because we test for so many diseases, about a third of donors will carry at least one thing. A third of the population is large. All of us carry some mutations. But these diseases in general are ones that require one copy from the egg and one copy from the sperm provider. And so, for example, if the egg donor carries a disease in general, we'll give an option to have the sperm source, the father or the sperm donor, the ability to test for the same diseases. And so long as both the egg donor and the sperm the sperm source don't carry the same genetic disease, then it's fine to move ahead, with the exception of certain diseases that we call X-linked, in which case if the donor carries these, she would be excluded from our program and you wouldn't actually even see her because she would not be accepted because of the high risk of transmitting that to the next generation. And we do a rigorous psychological screening. We use a tool called an MMPI, which is a psychological assessment that's been used for many years. It's a questionnaire, and then our clinical psychologist uses that information in order to discuss all of these issues with the donor. The donor then also has a conversation to make sure that she feels good about her donation and understands that it will be anonymous to the extent possible and has an opportunity to have all of her questions answered. So what's the process for the egg donor? The egg donor undergoes an IVF cycle. That means about 10 days of injections, multiple visits, 4, 5, 6 for blood hormone levels and ultrasounds during that process. And then she undergoes an egg retrieval under a little bit of twilight anesthesia. And that's the end of her donation. That egg is then mixed with sperm on the same day of the donation. We time things very carefully so that if the male comes in to provide a sperm sample on that day, that the egg donor and the male are not in the office at the same time. But you can freeze the sperm and use it at a later time. And of course, it can come from the intended father or a sperm donor. And then finally, the embryos are nurtured, they're grown in our lab for 5 or 6 days. We can do 2 different things. We can transfer the embryos fresh, which means that the donor has her egg retrieval, and then on the 6th day after the retrieval, 5 days later, the embryos are transferred into the intended mother. That requires the recipient of the embryos to be synchronized. Her cycle and the egg donors need to be synchronized. It does make the cycle a little bit longer because the egg donor and the mother are not usually going to have the same exact cycle. The option that we find better is that the egg donor does her cycle, the eggs are retrieved, they're fertilized with sperm, and then they're grown for 5 days, and then they're frozen. Then the mother can have her lining be prepared in anticipation of the receiving of the embryo, and that can happen really at any time that's convenient for her and does not have to be synchronized. And almost always we will transfer only 1 embryo at a time. Our success rates are quite high, and we want to make sure that the pregnancy is as safe as possible. Even when you transfer just 1 embryo, there is approximately a 2% chance that that embryo will split in half and make identical twins. And so we wanted to limit the risk. Obviously, the more the twins have a higher chance of preterm delivery and other complications. And the goal number 1 is to have the healthiest pregnancy possible. What about the emotional aspects? It's not an easy decision. Like I said, the hardest decision is whether to go ahead and have your family with an egg donor. There's a loss of a genetic connection. And while I will say that this is the most difficult part of this to internalize for many couples, once the baby is born, and really once you see a heartbeat and you see that there's a pregnancy in your body, all of those feelings of loss really get much better, and you just are more excited about the pregnancy than anything else. Those feelings don't ever go completely away, but much greater are the feelings of happiness and family building. And we recommend that the parents and also obviously the donor meet with a psychologist or social worker to talk about these feelings of loss, to discuss disclosure decisions, what you're going to tell the baby, how their origins, the origin story, and then impact of the relationship on the intended parent. How do you feel when one of you is providing genetic material but the other is not? How does that affect the relationship? In some cases, we use donor egg and donor sperm, but either way, it's important to talk about how that affects the marriage or the relationship moving forward. And there are legal aspects. So the donors sign a contract basically saying that they relinquish all the rights to their eggs. The recipients, or what we call the intended parents, assume full parental rights and responsibilities for any resulting children. So the donor can't come back and say, I want this baby that was created with my egg. But similarly, the recipients can't go back to the egg donor and say, well, we want you to pay child support or something like that. That is not something that's ever happened, and you're contractually protected. And then there's also a back office contract between the intended parents and donors that a lawyer oversees. So you have multiple layers of protection, as does the egg donor. And there are the financial aspects. So there are obviously medical costs, several medical costs. First of all, the egg donor undergoes an IVF cycle. Sometimes insurance covers this, sometimes not. The intended parent, female, has to undergo preparation of her lining in anticipation of receiving the embryo. And medications have to be given to both the egg donor to stimulate the ovaries and the recipient to prepare the lining. And then there's cost to the genetic and psychological evaluation. There's also a series of non-medical costs. The donor often is reimbursed for her time, effort, risk of donating. There's a fee for cycle coordination and often an agency fee as well if you use an agency and not a fertility center. So some costs, like I said, may be covered by insurance, usually only the medical aspects of it. But the donor reimbursement, what the donor gets paid for the donation, is never reimbursed. And now I want to turn it over to Vicki, who will talk about the gestational surrogacy half of our talk. And then at the end, we will answer any questions that you have. So please, I remind you to type them into the Q&A box. Thank you so much.
Thank you, Dr. Clipstein. So now we are going to talk about gestational carrier cycles. Um, just to kind of bullet point what we're going to go through. We're going to cover reasons to use a gestational carrier, characteristics of a GC, finding one, how we screen them, the process of coordinating and matching, and then additional considerations such as emotional, legal, and financial aspects. So first things first, I wanted to cover this right out of the gate. Gestational carriers are not the same as surrogates. These terms are often used interchangeably, but they are not the same. There's actually a pretty significant difference between the two, and that is that a gestational carrier has no genetic link to the baby. The egg provided for the pregnancy that she carries is from the intended mother or from an egg donor, whereas a surrogate provides the egg for the pregnancy, so she does have a genetic link to the baby. Traditional surrogate cycles aren't as common, and we don't do them. And the reason for that is the concern about the connection between the surrogate and the baby. So these would be the cases you would have heard about in the news where the surrogate delivers a baby, decides she wants to keep it. The intended parents are then heartbroken, out that time, out that money, and they're going home without a baby after all of this hard work. So today we're going to focus on gestational carriers and not traditional surrogates. This is a pretty simplified step-by-step process of how it works. I promise it is detailed, but just to kind of give you the breakdown, the very first thing is that the intended parents need to create an embryo for us to transfer to their carrier. So the egg can be provided from either the intended mother or an egg donor, and the sperm would be provided from either the intended father or a sperm donor. So the embryos are created and then they're frozen. We keep them at our clinic in our embryology lab until they're ready to be thawed to be transferred to the carrier. The carrier then starts her cycle. So she takes hormones to prepare her lining for the transfer. She comes in for blood draws and ultrasounds so that we can monitor her and make sure that we're transferring that embryo at the prime time for implantation. The embryo transfer occurs at a very set time. Everything in fertility is timed. So there's a very specific time that she needs to be there for her embryo transfer, and the intended parents are usually present. If they can't be there for any reason, we have before had them there virtually. The carrier, when she undergoes her transfer, is awake. There's no sedation, anesthesia, anything like that. So she could bring in her cell phone and either FaceTime, Skype, Zoom, whatever app she wants to use so they can feel like they're there as well. And it's the worst part, waiting for the pregnancy test. It's about 10 days after the embryo transfer that the carrier has her pregnancy test. It's totally nerve-wracking. The intended parents are pacing around, the carrier is pacing around, us at the clinic are pacing around because we do get emotionally involved in these cycles. It's so hard not to. So the news is really for everyone. It's mostly for the intended parents, but really we all are involved. The carrier then is monitored for early pregnancy monitoring with the fertility center. And then once the pregnancy is well established, she's released to the care of her own OB. So reasons to use a gestational carrier. There are a lot. First would be recurrent implantation failure or recurrent pregnancy loss. Like Dr. Clipstein spoke about with egg donors, same-sex couples or single men who want families. Absence of a uterus, either from birth or surgical removal. Medical reasons making pregnancy dangerous or unadvisable. For example, if the intended mother is on a medication that is not pregnancy safe, but she really can't get off of, that would be a reason for her to use a surrogate. And uterine issues such as scar tissue, fibroids, different things like that. So characteristics of gestational carriers. Number one, they have to have achieved a pregnancy of their own and delivered their own child. They have to have at least one. They have to be fairly young. The average age is 35. They have to be healthy. So we request all of her medical records, pregnancy history records, labor and delivery, vaccination records, everything, just so we can see, are there any red flags? Are there any reasons that we on paper would want to say, maybe this isn't the right match for you? We also want her weight to be within a normal range. We need her to be emotionally stable. This seems pretty obvious, but we're going to pump her full of hormones and send her on her way. So maybe we want to know that she's okay. We need her to have a good support system at home as well. And we need to make sure she's able to commit to the lengthy process. So this isn't a one-day thing, the transfer is one day, but she needs to be available to the intended parents, the doctors, the lawyers, the agency, to everyone from before the process starts until after the delivery of the baby. And most importantly, she needs to be a good fit with the parents. Just because someone looks good on paper doesn't mean you're going to click when you meet. So how the agencies normally work is they show the intended parents the profile for the carrier. They get the okay, then they do the reverse and get the okay, and then they schedule a virtual meet. If there's no click, that's okay. This is way too important a decision to pick someone that you don't have those feelings about. You certainly don't want to settle or choose the first one available. So it's really important to make sure that you do get that good match. Where do you find a gestational carrier? So you could use a family member, friend, acquaintance, a friend of the family, or a surrogacy agency. If you choose to use a surrogacy agency, which is the most common, it's going to be a long process. It takes a long time to get matched with the right person, which is what you want. If you already know them, that's a little bit different because you're not wanting to go through and, find out all these things that you didn't already know about them. Some considerations to take into account are if she lives in the state you live in or if she lives out of state. This is important for two reasons. The first one is the surrogacy laws in the state in which she will deliver. We'll go over that a little bit later. But it ties into also the amount of contact desired during the pregnancy. So if you want to be present for the embryo transfer, ultrasounds, delivery, everything, you might not want someone that lives a flight away from you. You might want them closer to you. And shared values. So shared values is something I never would have thought about before I had this position, but it's so important. And shared values, how we're using them today is in regards to the carrier's diet, her activity and exercise levels, and her environment. So to share a story, we had a couple who was matched with a carrier. She was already pregnant and released to the care of her OB. And the couple went to one of her pregnancy ultrasounds. Everything was fine. They didn't say anything to her, but when they got home, they called their lawyer freaking out because she had an iced coffee in her hand and she had mentioned that she had a bologna sandwich earlier. They were in full-on panic mode that she's having any caffeine and processed foods, and the attorney had to call them right away and tell her she can't eat and drink this way. Then they called the agency and told them the same thing. And then they called me. And thankfully, I was able to talk them off the ledge and explain to them if all three of us come at her and say, hey, you can't do these things, she's going to feel under attack. And they were like, yeah, but if we tell her, she's going to think we're so demanding and so crazy. And I said, okay, but let's flip the script. What if it was the other way? What if you were doing something she didn't like? Do you want to hear it from the attorney, the agency, and me, or do you want to hear it from her? So long story short, they called her, they told her, first of all, we know we're crazy, but we need to have this conversation. And they cleared the air and everything was so much better afterward. They had agreed on a safe caffeine intake, that they got the recommendation from her OB, and she agreed to limit her intake of processed foods. So it's really something, it should be talked about, it should be worked out, but it is an important thing. Screening the egg donor, carrier. So like we said, there is medical screening. We request her records. We also perform a physical on her in the office. We check her hormone levels to make sure that those are within normal range. And we perform a cavity study, which is usually a saline-infused ultrasound. She also has to undergo psychological screening. If she has an intimate partner, they need to go with her as well. Same for infectious disease screening. If she has an intimate partner, they have to be tested as well. And the testing includes HIV, hepatitis B and C, syphilis, chlamydia, gonorrhea. So additional considerations, emotionally, both the intended parents and the GC and her partner meet with a psychologist or social worker. This isn't to be told, you're too crazy to do this. This is to help all parties involved process their feelings and think about things they maybe hadn't thought of in the excitement of the moment. So the mental health professional is really a great resource for everyone. As far as legal is concerned, the attorneys draw up the contract between the carrier and the intended parents that sets the expectations and limits of the relationship. Again, how involved do you want to be? How involved does she want you to be, etc. It also describes various scenarios and determines how they would be handled. For example, what if the carrier's OB wants to do a kind of invasive test like an amnio? Do the intended parents agree to this? Does the carrier agree to this? Or what if the carrier's put on bed rest for a lengthy part of her pregnancy? How is this going to be handled? And then financial, of course. There's the IVF cycle for the intended parents to create their embryo. There's the cycle to prepare the carrier's uterus for the transfer, reimbursement to the gestational carrier, health, life, disability insurance, and then under miscellaneous fees, there's a ton. Clothing, travel, legal, medication reimbursements, pretty much everything you could think of. The agency should have on a fee schedule available to you, and the attorney should work into the contracts for you as well. So Illinois Gestational Carrier Act is my favorite. It's like the best reason to live in Illinois, I think. It was put in place in 2005 to establish consistent standards and procedural safeguards for the protection of all parties involved in a gestational carrier contract in this state, and to confirm the legal status of children born as a result of these contracts, which is really just a fancy schmancy way to say we have a law in place in Illinois that sets the guidelines and the standards for surrogacy arrangements. As you can see on the map on your screen, this isn't the case in every state. So it all depends on where the carrier is delivering. Not all states have laws governing the surrogacy arrangements. So if you have a carrier, for example, that lives in Washington State, you might want to see if she can deliver in Oregon or, somewhere else. We have worked with couples that have had their carrier deliver in a state she didn't live in if they lived close enough to the border. Super exciting news though. Surrogacy will be legal in New York in 2021. It was kind of surprising to me that such a progressive state didn't have a law in place. But I'm so excited to see that they are moving in the right direction, and hopefully that gets other states to follow suit. So I'm going to ask Dr. Clipstein to come back and we can go over concluding thoughts and answer any questions that you may have submitted.
Hi there. So just in conclusion, as you've seen, there are many ways to create a family. Deciding to seek the help of an egg donor or gestational carrier, of course, adds complexities to the family building journey. But really, the way I see it is that through the strong desire, hard work of the intended parents, these children are both imagined and born. If you didn't conceive of the idea of being a parent, whether you use a gestational carrier to help you, whether you use the assistance of an egg donor, these babies would not be with us. And so really, they're very lucky babies and very lucky parents and very desired children. And so it's very exciting to be able to offer this service and to see all the happiness that comes from it. Often starting with a lot of despair and a lot of doubt. And then I think Vicki can also attest to this, that we see people sort of at their lowest point, and then we see them leaving us so happy and smiley and just thrilled to be on the journey to becoming parents. So we have a couple questions that came up. Vicki, do you want to start with asking of the egg donor questions, and I have a few for you about surrogacy?
One popped up that either of us could cover, but I'm going to throw it at you. And that is embryo adoption available as a possibility for a couple?
Yeah, so it's interesting. We call this embryo donation because we don't see it really as an adoption because there's no baby to adopt yet. But yes, we do embryo donation. And oftentimes couples, once they have completed their family through IVF, they sometimes have extra embryos, and not wanting to discard them or donate them to research, which are some of the options, they choose to anonymously donate them to another couple. So this is a great option. And one of the questions also was, if you don't have egg or sperm and you need both, can you use embryo donation? And absolutely we can. And we've had lots of wonderful outcomes with that option. So definitely. A question I have about the gestational carrier process for Vicki. What happens after the pregnancy test? So the gestational carrier finds out she's pregnant, everybody celebrates, and then can you talk a little bit about how long we monitor that pregnancy, what the gestational carrier does later, how their relationship evolves once the patients leave our care?
Sure. So you were right with the first step. We all celebrate after wearing out holes in the carpet, pacing around. Once we get that positive test, we're excited. We all call each other. There's usually crying. We just can't help it. The carrier is then told to return in 2 days to have a repeat blood test. And we want to see that the level about doubles. It doesn't have to be exactly double. Some people get a little crazy and, you know, oh, it's 1 point off. Totally fine. Not a big deal. 1 week from that second blood test is her third and last blood test. And at that point, we just want to see that the level has continued to increase. She also has her first ultrasound. And on that first ultrasound, what we're looking for is just a gestational sac. It's just a little jelly bean showing up on the screen, but it will be the highlight of everybody's day. Depending on how the pregnancy is progressing, she will have an ultrasound the following week, 1 week later. And possibly we might see heartbeat on that ultrasound. Once we see that heartbeat is above 120 beats per minute, at that point we feel it's a well-established pregnancy, and we have a closeout appointment with her and give her her records and send her back to her OB, where she's then monitored throughout the rest of the pregnancy, labor and delivery by them.
Thank you. That's super helpful. Another question came up. Can you use an egg donor if you've gone through menopause? And the answer is absolutely yes. This is a common reason why you might need an egg donor. So, you might go through menopause at the normal age and want to have a baby then. You might have gone through menopause earlier than is average and not realize that this was going to happen to you, and now you need to avail yourself of an egg donor. Certainly some women never get their periods for various medical reasons, and so for those women, absolutely, it's the only way that they can have carry a baby. And then also the treatments, like I spoke about a little bit earlier, cancer treatments and so on can affect when you go through menopause. And so sometimes young women go through menopause after treatment for different types of cancers. And so absolutely you can use an egg donor. The body, menopause really is just the end of your egg production. And we can replace that with a donor egg. And then what's really interesting is that for these types of treatments, you need to replace all of the hormones that a woman needs for the first trimester of pregnancy. But then as soon as the placenta is established, the body starts making all the hormones you need. And even a woman who has been in menopause for many years can make all the hormones that she needs to support the pregnancy. It's really pretty miraculous what the body will do. So yes, we can and we do all the time do egg donor cycles for women who are menopausal.
So we had one more question come in that I kind of want to answer with you, make sure that I understand properly. And they're asking, is there a difference between fresh or frozen embryo implantation chance of conception? So my understanding, one of the things that I have to do is monitor our rates and provide them to the physicians. And historically, frozen embryo transfer rates do have a slightly higher success rate. So Dr. Kripstein, first, verify that I'm not lying, and two, maybe provide some insight as to what you think.
Yeah, I mean, in theory, the rates should be equal, but what we found is that when you don't need to synchronize the two cycles, everything is a little bit easier, and then we can much more kind of happily fine-tune things. So for example, if a cycle is synchronized, but the lining of the recipient of the intended parent is not perfect, or we think the donor should have one more day of stimulation medications, it's much harder to do when you're trying to synchronize a cycle. When you use a frozen embryo, you have a good quality embryo, and then you can make sure that the lining that embryo is going into is also perfect. And if it's not perfect, you can wait another cycle or another day or another week, whatever it takes, and make sure that everything's perfect. So we very much like to do these cycles frozen. There's a lot less pressure on everybody involved, and the success rates are at least as good, if not a little bit better.
All right, I think we've covered all the questions. We're going to have Brian come in and give his closing.
Thank you, Nick. Thank you very much. All right. Thank you all so much for attending this webinar. Thank you to Dr. Clipstein and Vicky for sharing this information with us. Please check out our website, inviafertility.com, for recordings of this and previous webinars. For more information, you can also follow us on Facebook and Instagram. If you have a question we didn't get to, or if you think of something that you would like to ask after this has ended, please send it to info@inviafertility.com. Again, that's info@inviafertility.com. Thanks again, everyone. Stay safe and stay healthy.
Thank you.
you.